Welcome to the Medical Nursing Unit, Topic 1, Disorders of Respiratory System. Before continuing with respiratory disorders, let's see a summary view of anatomy and physiology of respiratory system. The parts of respiratory system, we know we have the nasal cavities, nose, and linked air passage, mouth, larynx, trachea, bronchi, bronchioles. This is small thin tube. Alveoli, the alveoli, this is the air sac connected to the bronchioles. We have capillaries. The capillaries, this is a network of thin blood vessels that cover the alveoli. Capillaries connect to the network of arteries and veins. Pulmonary artery delivers blood containing carbon dioxide to the capillaries of the alveoli. Diaphragm. The diaphragm is the main muscle for breathing, located below the lungs. It separates the chest cavity from the abdominal cavity. Also have intercostal muscles. Intercostal muscles are located between the ribs. Intercostal muscles assist in breathing. We have also abdominal muscles. The abdominal muscles are used to exert when breathing fast. We have also accessory muscles. We have neck and the collarbone. Are used for breathing when the patient is having difficulty breathing. Respiratory system function. Nose and mouth, wet and warm air. Cold and dry air irritate the lungs. That's why the nose and the mouth, wet and warm air. While we are breathing, when we breathe the cold or dry air, that will irritate the lungs. It is very important. The nose and the mouth are very important in wetting the air. Cilia in the nose and the airway trap germs and other foreign particles in the air. Though the cilia we see in our nostrils are very important, you can see they trap germs. You will see where you are traveling anywhere and you breathe in the dust. You will see that where you sneeze, you will sneeze upward, sneeze back the dust. So the cilia trap the germs and other foreign particles in the air. It is very important. When somebody doesn't have enough cilia in the nose, we have also a problem. The dust and the foreign particles will enter into lungs. Particles are swallowed, coughed, or sneezed out of the body. Yeah. When the particles are trapped in the nose by the cilia, they will be swallowed and will be coughed, sneezed out of the body. The lungs exchange oxygen and carbon dioxide from blood vessels. We know very well for the blood circulation. The blood from the right heart carry more carbon dioxide than oxygen. So there is an exchange at the level of alveoli. So there will be exchange and carbon dioxide exchange to oxygen. Carbon dioxide will be exhaled and the oxygen will be carried by the blood to the system. The pulmonary artery delivers blood containing carbon dioxide to the capillaries of the alveoli. Gas exchange takes replacing carbon dioxide from hemoglobin in red blood cells with oxygen. Let's see other function of respiration. Airway carries oxygenated air to the lungs and removes carbon dioxide. muscle around the lungs expand and contract to force the lungs to exhale and inhale. These muscles are inhalation muscles. The inhalation muscles, the first is the diaphragm contracts. The diaphragm contracts, moving down increased space in the chest cavity and enabling lungs to expand. Intercostal muscles pull the ribs cage out and up, enlarging the chest cavity. Air sucked through the nose and mouth as the lungs expand and travels down the trachea and the bronchi. The bronchioles and the two alveoli, where gas exchange will occur. Differently to inhalation muscles, where as you have seen, where the diaphragm contracts, moving down increased space in the chest cavity, and intercostal muscles pull the ribs cage out and up, enlarging the chest cavity. In the exhalation muscles, the diaphragm and intercostal muscles contract, reducing space in the chest cavity and forcing air out of the lungs. To understand very well how we breathe in and breathe out, let's use two systems. You have two volumes now, and we have the gases in the atmosphere and the gases in the lungs. Remember that the gases move from the higher pressure to the lower pressure. Now, as you have seen there, when in inhalation, you have seen that the diaphragm contracts. The diaphragm contracts and moving it down and increase space in the chest cavity. And the intercostal muscles pull the rib cage out and up and arranging the chest cavity. Here, when the diaphragm contracts and the intercostal muscles pull the ribs, they will increase the volume. They will increase the volume of chest. Now, as we increase the volume of the container, we decrease the pressure. Okay, the pressure. So when we are decreasing the pressure, so we will allow the movement of the airs of gases from the higher pressure to the lower pressure. What will happen, of course, during breathing inhalations, so the diaphragm will contract, and the intercostal muscles pull the ribs cage out, and there will increase of the chest cavity, and we'll have a negative pressure, while in atmosphere, comparably to the atmosphere pressure will be high, and in the lungs the pressure will be low. So the air will move from the atmosphere into the lungs. This is inhalation mechanisms. Okay, but contrary in exhalation, those muscles, diaphragm and intercostal, will not increase the cavity, but we reduce the cavity. No, we reduce space in the chest cavity. While we are using the volume of the cavity, we are creating positive pressure in the chest. So when you get the positive pressure in the chest, means while we are reducing the volume, we increase the pressure. Comparable to atmosphere, okay, atmosphere will have a negative pressure, so the air will move from the lungs to outside. This is exhalation. Okay, let's continue and see respiratory control. The respiratory are controlled by the medulla oblongata portion of the brain that control breathing. Sensors in the carotid artery and aorta detect carbon dioxide and oxygen levels in the blood. So these sensors signal when respiration should increase or decrease. Sensors in the airway detect irritants and trigger the brain to cause coughing or sneezing by tightening smooth muscles around the the airway, increasing the air pressure on exhalation. Sensors in the alveoli detect fluid build up and signal the brain to trigger rapid, shallow breathing. Let's see together breathe sound. Breathe sound comes from the lungs when you breathe in and out. The sound can be heard using a stethoscope or simply when breathing. Breathe sounds can be normal or abnormal. Abnormal breathe sound can indicate a lung problem such as obstructions, inflammation, infection, fluid in the lungs, and asthma. Okay, you have seen that the doctors, physicians, and the nurses use it to auscultate the lungs at the chest or at the back. Here, they want to detect which sound. So the sound determine, this is how the air enter in the lungs. Where they enter in the lungs, they create sound. And this sound can be normal, abnormal. And how is the sound? The characteristics of sound will determine the problem of the lungs. We can determine obstruction. When the lungs are obstructed, so we will hear the typical such sound. And inflammation, infection, fluid. When there is a fluid, when the air enters in the lungs with the fluid, we will hear a typical sound. And when the client is having asthma, like in obstructions also, now we have a typical sound. What are types of sound? Now, a normal breath sound is similar to the sound of air. However, abnormal breath sound may include long I. This is a low-pitched breath sound. Crackles, a high-pitched breath sound. Wheezing, a high-pitched whistling sound caused by narrowing of the bronchial tubes. Example, during asthma. During asthma, we will hear the wheezing sound. And stridor, this is harsh, vibratory sound caused by narrowing of the upper airways. Now, we will see for the client with the advanced sinusitis. Now, sinusitis, when there is any obstruction of the airway, upper airways, we will see the stridor. Now, while you auscultate, you can understand now. Now, this is now. What is the difference between wheezing and stridor? Both can highlight an obstructions, but during a wheezing, we will hear the wheezing sound in exhalation when the patient or the client is exhale, but we will hear the stridor when the client inhale the air. So this is the some difference now. For wheezing, when the client exhale; for stridor, when the client breathing. When they breathe in, we are here the harsh vibratory sound. This is stridor. Okay. For clackles, this is high pitched breath sound. This most of the time we hear the clackles when the client is having pneumonia. Pneumonia, and we can have a long I. This is a low pitched breath sound. When there is some fluids, there is more fluid in the lungs, we can hear the bronchitis. Okay, now those are the main types of breath sound. Okay, what are the causes of abnormal breath sound? Abnormal breath sound are usually indicators of problems in the lungs or airways. The most common causes of abnormal breathing sound are pneumonia, and you have seen that in the pneumonia we mostly hear the clackle sound. Okay, to have heart failure also. The heart failure can cause also the abnormal breathing sound. Chronic obstructive pulmonary disease such as emphysema, asthma, bronchitis, and foreign body in the lungs or airways can cause an abnormal sound. We will see those abnormal sound typically at the particular respiratory pathology. For more explanations, bronchi occur when air tries to pass through bronchial tubes that contain fluid or mucus. And the clacks occur if the small air sacs in the lungs fill with fluids and there is any air movement in the sac, such as when you are breathing. The air sac fills with fluid when a person has pneumonia or heart failure. Wheezing occurs when the bronchial tube becomes inflamed and narrowed. Stridor occurs when the upper airway narrows. Remember that the difference between wheezing and stridor is that the wheezing is heard when the client is exhaling, while the stridor is heard when the client is inhaling. Okay, now this is some difference between wheezing and stridor, but both indicate an inflamed and narrowed airways. But most of the time, wheezing is from the bronchis, but stridor in the upper airways. The typical difference is the breathing and breathe out. We heard the stridor when you are breathing, and we hear wheezing when you are breathing out. Okay. Here we have a summary of auscultation. Now when you want to hear those breath sound, now you can see we auscultate back and we auscultate on the chest. This anterior and the posterior, those are the landmarks. Of course, this is the landmarks of auscultation. Maybe we see them very well in the assessment unit. Okay, let's now start the disorders of respiratory system. The first disorder is bronchitis. The bronchitis, this is irritation of the bronchi. Can be caused by infection, maybe from viral or bacterial or airborne. Those irritants causes inflammation that decreases mucus production, leading to blocked airway, bronchi, and decreased gas exchange. We have acute bronchitis and chronic bronchitis. For acute bronchitis, is reversible within 10 days. But by chronic bronchitis, this is not reversible and is classified as chronic obstructive pulmonary disease, and is defined as a productive cough that lasts 3 months in each of 2 consecutive years in a patient in whom other causes for cough have excluded. And the cigarette smoking is by far the major risk factor for chronic bronchitis. I think this is understandable. What are the risk factors for bronchitis? I have seen the smoking is a major risk factors, but also air pollution, exposition, lung irritant, and disease of the lungs, such as lung cancer, congestive heart failure, or emphysema, can be the risk factors for bronchitis. What are the signs and symptoms of bronchitis? The typical signs of bronchitis is what the first is the productive cough for acute bronchitis, but for chronic bronchitis, cough for 3 months. This is cough for 3 months. We need to differentiate now the acute bronchitis and the chronic bronchitis now. And we have dyspnea, wheezing, use of accessory muscles to breathe. We can have a fever and weight gain, causes of edema. Okay, the risk factors for bronchitis. Smoking is the first, but also air pollution exposition, lung irritants, and disease of the lungs, such as lung cancer, congestive heart failure, or emphysema. What are the signs and symptoms of bronchitis? The first thing, the typical one, is a productive cough. For chronic productive cough, lasts for 3 months. That will be called chronic bronchitis. The cough will be associated with dyspnea, wheezing, use of accessory muscle to breathe, fever, and weight gain because of edema that from light-sided heart failure. Dyspnea, wheezing, use of accessory muscles to breathe, fever, and weight gain because of edema from right-sided heart failure. What are the medical tests for bronchitis? We can test arterial blood gases that will show respiratory acidosis. With the hemoglobin will increase, and chest X-ray will show infiltrate related to infection. Pulmonary function test will show forced vital capacity decreases, forced expiratory volume in 1 second, residual volume will increase. What are the treatments for bronchitis? For acute bronchitis, the goal of treatment of acute bronchitis is to control symptoms such as fever, cough, and shortness of breath, and to minimize the development of serious complications such as pneumonia. The first steps in the treatment is prevention. How do we prevent the bronchitis? And we have seen the major factor that contribute to the acute bronchitis is smoking. Now, the risk of developing acute bronchitis can be reduced by not smoking and avoiding air pollutant. In the treatment also, we have to have a rest and to take fluids. How to take a pain relief such as paracetamol or aspirin. Cough suppressant can use such as codeine, bronchalen in case of dry cough. Also can take antibiotics such as amoxicillin in case of bacterial bronchitis. We have seen that we have the bronchitis can be caused by bacteria or virus. What the difference? While we have a fever, when you detect a fever, you mostly suspect the bacteria or bacterial bronchitis. Here we administer the antibiotics. Other treatment is physiotherapy. The physiotherapy, this is respiratory exercises, postural drainage. This is to facilitate the coughing coughing out the mucus. And we can give you humidifier. The humidifier is to try to thin out sputum, avoid very cold weather. While you are suffering from bronchitis, you avoid very cold weather because it can aggravate the situation. For the chronic bronchitis, you have to administer beta-2-adrenergic bronchodilator. Example, this is salmeterol or albuterol and etc. We can give steroid to decrease inflammation. Example, hydrocortisone, prednisolone. Okay, we can give methylaxanthine for bronchodilation. Example, we have aminophylline, theophylline. We will also give diuretics to decrease fluid. Example, this is furosemide or Lasix. We can also give proton pump inhibitors, decrease the risk of aspiration and the gastric stress uresa or gastric stress uresa. Yeah, this is, we can give omeprazole, and we can give H2 blocker. This is lantidine or cimetidine. We can give antacid, aluminum hydroxide, magnesium oxide, calcium carbonate. Expectorant to liquefy secretion also can be given, and you can give anticholinergic to reduce bronchospasm and antimicrobacterial. What are interventions? We can use incentive spirometer. So incentive spirometer, this is a material we use to increase or to expand the lungs. So we breathe in and you create a deep breathing in the spirometer. And for exercises, this is being done for lungs exercises. Another intervention, you have to give it to the patient a high Fowler's position. This is the semi-sitting position. The cat can take a 3 liters of fluid daily to help liquefy secretions. If necessary, we can give oxygen therapy 1 to 2 liters via nasal cannula. We will monitor vital signs, monitor sputum changes, we will monitor fluid intake and output, increase fluid to keep mucus thinner and easier to expel. What we will instruct to the patient: instruct to administer oxygen, instruct to turn, cough, and employ deep breathing exercises, when using spirometer, incentive spirometer if you have it. If you don't have it, the client can exercise deep breathing to increase calories and protein in the diet. Also how to increase the vitamin C in the diet. Let's see chronic obstructive pulmonary disease. Definition. COPD is a disease state in which airflow is obstructed by emphysema or chronic bronchitis or both. Asthma used to be considered with the disease group of COPD, but it is now considered a separate disorder, classified as an abnormal airway condition characterized primarily by reversible inflammation. However, in some cases of asthma and in some cases of COPD, airflow obstruction may be irreversible. Because of this overlap, asthma is included in this discussion of COPD. Normally, by summary, the COPD, this is a chronic obstructive pulmonary disease. It is related by emphysema and chronic bronchitis, or both. We will consider asthma as a part of COPD disease when the asthma is not reversible. We know that for the asthmatic, this is an acute disease. There is an inflammation, and we give drugs, and the disease reverses. Okay, but when the asthma is not responding to the drugs, the inflammation is not reversing. So we will take this asthma in the COPD disease. Clinical manifestations of COPD. We have dyspnea, cough, increased work of breathing. Weight loss is common because dyspnea interferes with eating, activity intolerance, use of accessory muscles. Clinical manifestations specific to the disease that cause COPD are discussed in detail later. What is the risk factors? Exposure to tobacco smoke amount for an estimated 80% to 90% of COPD cases. Passive smoking also. If you don't smoke but you live together with anyone who smokes, this is passive smoking. Occupational exposure also can be a risk factor. Ambient air pollution, genetic abnormalities, including a deficiency of alpha-1 antitrypsin, an enzyme inhibitor that normally counteracts the destruction of lungs tissue by certain other enzymes. Okay, when genetically you have abnormal or a deficiency of this enzyme, alpha-1 antitrypsin enzyme, you can also develop the COPD. What are the complications of COPD? we will have respiratory insufficiency and failure and major life-threatening complications of COPD. Other complications of COPD include arthritis. The arthritis, what is it? This is a collapse of air sac of alveoli. When we say a collapse, this is maybe there is an obstruction in the proximal part of alveoli that will impede the air to enter into alveoli. That will cause we call the abscess, total abscess of the air and the collapse of alveoli. Okay. Another complication is the pneumonia. The pneumonia, this is an inflammation of lung cells, lung parenchyma, and the pneumothorax. The pneumothorax, this is the accumulation of air in the pleural cavity. And we can have a mediastinal subcutaneous emphysema, and pulmonary hypertension also can be a complication of COPD. In medical management, we will have inhaled bronchodilator are often used to provide direct bronchodilator action to the airway, thereby improving airflow. We can have long-term oxygen therapy. This is maintenance of a constant adequate oxygen saturation, more than 90%. Let us see chronic bronchitis in the details. It is defined as a productive cough that lasts 3 months in each of 2 consecutive years in a patient in whom other causes for cough have excluded. The cigarette smoking is by far the major risk factors for chronic bronchitis. Other risk factors include second-hand smoke inhalation, air pollution, and occupational exposure to hazardous airborne substances. How can we summarize the pathophysiology of COPD? We have seen that the COPD, the risk factor for COPD are the tobacco, smoke, and air pollution that will irritate the lungs. Okay. Now, also, I have seen that the COPD is characterized by 2 diseases. It's caused by 2 disease conditions: chronic bronchitis and emphysema. When we want to show the pathway of how chronic bronchitis can cause COPD, what happened now? We are exposed to the smoke and air pollution that will be the continual bronchial irritations and inflammation that will lead to the chronic bronchitis. Okay, it will be said chronic bronchitis because we have bronchial edema, hypersecretion of anemicas, chronic cough, and bronchial spasm. This will lead to air obstructions, air trapping, dyspnea, and frequent infections. Okay, that will result the abnormal ventilation perfusion ratio, hypoxemia, hypoventilation, and copulmonary. While hypoxemia, this is the low oxygen in the blood. Okay, but the pathway of emphysema. Okay, we have also expositions or risk factors: tobacco smoke, air pollution. But also we will have a contribution of alpha-1 antitrypsin deficiency. This is the enzyme that protects the connective tissues in the lungs. Okay, when there is a deficiency or the absence of this enzyme, now those connective tissue will be destroyed. Now there will be a breakdown of elastin in the connective tissue of the lung that will lead to emphysema. When we say the emphysema, this is a defection of alveolar receptor, airway instability. Now also emphysema lead to airway obstruction. This is the same as to the chronic bronchitis: air trapping, dyspnea, and frequent infection. Okay, now this is a summary of COPD disease, pathophysiology of COPD. What are the clinical manifestations of chronic bronchitis? You have a history of smoking, chronic productive cough, progressive dyspnea, intermittent wheezing, occasionally viral chest, prolonged expiration is always present, cyanosis is always present, chronic hypoventilation, polycythemia, cor pulmonale. The cor pulmonale, this is called called pulmonary heart disease, consists of right ventricular enlargement. This is cor pulmonale. Now this is pulmonary heart disease, consists of right ventricular enlargement. Okay. How to diagnose chronic bronchitis? We'll use now the physical examination, chest radiography, and blood gas analysis. The blood gas analysis. Okay. The treatment of chronic bronchitis. The best treatment of COPD is prevention because the pathologic changes are not reversible. Now, tell the people to stop smoking and avoid air pollution. Well, but in the case of disease, we will administer bronchodilator. The bronchodilators, in general, bronchodilators are used for symptomatic benefit in a patient with chronic bronchitis. The inhaled route is preferred for medication delivery as the incidence of side effects is lower than that seen with the use of parenteral medication delivery. And have here can give expectorants, chronic oral steroids such as prednisolone can be administered, and also supplemental oxygen is the only pharmacologic therapy demonstrated to decrease mortality in a patient with severe hypoxemia. Okay, for those people with the COPD also they need chest physical therapy. Thank you very much. Merci beaucoup. Murakoze cyane. Mukomeze mutere inkunga iyi channel, mukanda kuri subscribe ndetse no kunzogera kugira ngo ibindi bikurikira mujye mita mubibona uwo mwanya igihe tubishyizeho.